My name is Lars Lannfelt, professor at Uppsala University, and I've been doing research on Alzheimer's disease for more than 30 years. And before that, I did research on a rare inherited disease that has been studied a lot in Sweden, porphyria. I got an idea for a treatment for Alzheimer's disease more than 20 years ago. The idea was based on actually studying a family from northern Sweden. This family had an inherited form of Alzheimer's disease, and we found a mutation in that family, and we named it the Arctic mutation, as it came from the northern part of Sweden. We developed an antibody, or isolated an antibody, at my lab at Uppsala University. This antibody was a mouse antibody, and then the company BioArctic humanized the antibody to lecanemab. And on Alzheimer's disease, we have a new technology to increase the penetration of lecanemab into the brain. Antibodies, quite limited amount goes into the brain, but we have now developing a technology to increase the amount, that perhaps 70-fold increase of penetration into the brain. You can lower the dose and will have more effect of the antibody. So that will be a very important development. We call it brain transporter, but you can also call it shuttle. We use the transferrin receptor to increase the amount of antibody going into the brain. We will most likely reduce side effects. We need much less of the antibody, and you will have a bigger effect. That will be a very important development. The amyloid target is very important. All the genetic factors tells us that the disease starts with amyloid beta. Then there will be other pathological features like tau, phosphorylated tau you find in the brain. But with lecanemab, we target the soluble aggregates of amyloid beta, and we reduce also both total tau and phospho-tau with lecanemab. What will happen is we will have a subcutaneous formulation, so you can take it like insulin, which will facilitate a lot, because now with the infusion you have to go to some hospital or wards that you can't do it at home. But the subcutaneous patients and relatives will be able to make at home. That will facilitate a lot. But not oral, it's not possible with an antibody. Today we can see that when we treat early, we will have a better effect. And the diagnostic markers are developing very rapidly, so we can diagnose the patients much earlier. And this is a continuous development, so in 5 or 10 years we will be even better at diagnosing patients. And then I think with the brain transporter, my belief is that we can stop the disease completely, and that will be a great thing for patients and their relatives. We have now biomarkers also. They started with the biomarkers in the CSF, lumbar. You need to do a lumbar puncture, which is a little bit complicated, but we have done it a lot in Sweden, and we think it works very well. You can measure amyloid beta 42, total tau and phospho-tau, and these markers give us a very good help in the diagnostic process. Before we had these markers, in the clinical trials, up to 30% of patients did not have Alzheimer's disease, which was a great problem, of course. Now what's happening now is that we get biomarkers in the blood, which will facilitate a lot, And then we have the PET, amyloid PET camera measurements of amyloid beta. It's a quite complicated and expensive method, but it has been very important in the research. But for the clinical development, this blood biomarker will be very important, and it's different forms of tau, phosphorylated tau, you can measure in the blood, and they are elevated in Alzheimer patients. The other proteins like tau, phospho-tau, alpha-synuclein, they are a reaction according to my mind, to the amyloid beta pathology that initiates the disease. And if you target what is the key factor, I think we will also affect all the other proteins. We can see that now with the lecanemab, that both total tau and phospho-tau are affected in the right direction. I think it's possible to more or less cure it. I think so. And I think the data tells us this. If you look at the data from the phase 3 study with lecanemab, you can see, if you look at the very earlier part of those patients, you can see that some even improve. SC, the measurement, 30 points is what you can get at best, and the average point in the phase 3 study there were 25.5, and that means that they are fairly severely diseased, you know, and we can treat patient much earlier than that, and then we will have even better results. I was very happy for the prize I got in Paris. We can improve the diagnostics, probably also the therapeutics, but at my age, I think lecanemab is what I have done. Diagnostic work is extremely important, biomarkers especially, and the blood biomarkers. University research is very important, and I've got funding from many sources in Sweden, both the state and the private foundations. That has been extremely important for doing the research, both the clinical research and the research, the preclinical lab